the blood.
Cool.
Okay. And what are we worried about if the blood is clotted?
Embolism.
Right. So we can get an embolism, stroke, anything. We can look at any of those things. PE. I mean not PE, but an embolism that can go and block off the vessels of the heart, the lung, down below arteries, whatever. Okay. Usually a sign of serious heart problems. Treatment is usually medication or electrical cardioversion. Only done in the field if the patient is critical. So I'm going to go back to, here we go. What's it say over on the right side? Right. So if you see the patient in atrial flutter or atrial fib, and the blood pressure is fine, and they're hemodynamically stable, are you going to worry about that? Let them do that in the hospital. Let them take care of him there. Because if something goes south, right? So,
Bless you.
on the side of that, what medication can we use out in the field that we have?
Cardizem.
Okay? Does anybody know the dosage of cardizem?
0.25 milligrams per kilogram for your first dose and 0.35 for your second.
Okay. Okay. So again, treat the patient. If the patient is if the patient is bad, then you have to treat accordingly. Treat the patient, not the monitor. Okay. Atrial fib. So atrial flutter is sawtooth. Atrial fib is a quiver, random depolarization from atrial cells depolarizing independently. Okay, atrial fib, atrial flutter, atrial fib. Okay, so you see here, right? What do you notice?
He waves are all over the place.
Those are things.
79 files need to be backed up.
Okay, well,
Sherry, one day we're gonna have to sit down and actually back up those files.
Which one?
Oh,
All 679.
okay. Again, if you look at this rhythm here, if the patient presented this way right now, with a blood pressure of 130/90, are you going to treat this patient aggressively?
no.
Okay. So it's the patient we worry about. This is what do we call this? Pretty much stable AFib, right? I mean, it's as stable as it can be for right now until we get to the hospital. Okay? They're not. They could have chest pain. If there's chest pain, you're treating the. Right. If the patient has a blood pressure of 130/90 and there's a chest pain, are you treating the atrial fib or are you treating the chest pain? Okay. Okay. Irregular appearance, usually signs of a serious heart problem. Again, we talk about blood clots. We talk about the pooling of the blood in the ventricles. Pre-hospital treatments are rare. Again, it just depends on if the blood pressure is, if the patient is hypotensive, chest pain, then we have to treat the patient accordingly. What we would do. SVT, supraventricular tachycardia. Okay. Where's it occurring?
In your ventricles? In your ventricles? Oh, above.
Atria. The atria. Okay? Supraventricular tachycardia. The atria. It's happening in the atria. Tachyarrhythmia from pacemaker. It's exceeding 150 beats per minute. Okay? What does this mimic that you might think it's something else? Say it again. VTAC. How do you know it's not VTAC? Okay? You see a P wave there. It's there. I mean, is there something there? Huh?
QRS.
It's marching out. It's marching out. It's marching out. QRS is marching out. I mean, it's marching out, right? Okay? QRS complex is 40 to 120, right? May have Canon A waves. Okay?
What does that mean?
Canon A waves.
When they actually, think of a cannon, think of a fight and it's just shooting straight out. That's what they're talking about, a cannon A wave. Just,
Okay, so they're talking about the QRS.
yeah, just shoot
Straight
straight
up.
out.
Straight up.
You
See
know,
how,
that's all I can do.
right, so see how, right. She's right, yeah. See how thin it is, how small it is?
Sorry, I have to use the premise.
Okay. Remember, we're talking about rhythms in the atria. SV, supraventricular tachycardia. Okay. So, paroxysmal supraventricular tachycardia.
Comes and goes.
Okay? Explain. Comes and goes as what? There's a definition. There's a specific definition in it. What does it mean? Who said about it comes and goes?
With your activity level?
How long does it last for? Well, how long is it sustained? Why? How did they? There's a reason they call it, and it's sustained. Why do they call it paroxysmal supraventricular tachycardia? I looked it up. That's why I said it. You said it, and I was kind of wondering. Okay, supraventricular tachycardia often occurs in episodes with stretches of normal rhythm in between. When tachycardia occurs, it usually referred to paroxysmal supraventricular tachycardia, that it may be chronic or ongoing. Okay, so it could be short term, it could be long term.
It says in the book that you need to physically witness that change to be able to call it that.
Well, yeah, that makes sense, because otherwise how are you going to call it proximal?
Supraventricular tachycardia.
If you didn't see it go up and down.
Yeah.
So.
May reduce cardiac output. Okay, again, premature atrial complex. Complex with another rhythm. Upright P wave precedes each QRS complex. So it fires before, right? Premature. Non-conductive PAC. The P wave occurs on each of the EKG and is not followed by the firing of the ventricles, right? No QRS. So if it's premature, there's no QRS going to fire with it. Can result from drugs or organic heart disease. There is no treatment for this out in the field. Just look at it and say, yep, we take them to the hospital.
With PACs, do they come from an ectopic foci?
Mm-hmm. Again, we're talking about everything up in the right. Okay? Right, because it could be on the internodal pathways, it could be anywhere. Right? Wandering atrial pacemaker. Pacemaker moves from the SA node to anywhere other in the atria. Upright P waves precedes each QRS. At least three shapes of P waves within this strip. Do you see anything different with the P waves?
Some are taller, some are longer.
Here we go. There's three different ones.
That's Tylenol. Oh, crap. Wow. I could throw it like mannequin.
Stickers.
Okay. The wandering pacemaker, most common, significant lung disease. Treatment in the pre-hospital setting is not usually indicated for the wandering atrial pacemaker. MATs, multifocal atrial tachycardia. Again, the pacemaker moves within the various areas of the atrial rate above 100. Upright P waves proceeding by each QRS. The P waves could vary. Multifocal area are 120 to 200 milliseconds. Most common with significant lung disease again. Therapies for SVT are generally ineffective. So what do we give for SVT? Is this going to work?
Sometimes.
If it's done correctly, it should.
No.
By usage?
No, for this.
For this?
Oh.
No. For MATs? No. That's how you know that it's not working. You know it's not that when it doesn't work.
I can't do it anymore.
Okay.
Isn't your
What are you doing?
Or water.
Do you want some of my water? There's no water left.
I got some nice water from downstairs.
That's for the toilet.
It's from somewhere in the building.
Alright. Fill my cup.
Okay. So we've talked about the normal pathway of a heartbeat, right? We talked about the pacemaker with the SA to internodal to AV to all of that down there. We go into the bundle of His to the left and right bundle branch of Purkinje fibers. We've talked about rhythms in the atrium. Okay? Now we're going to talk about rhythms originating in the AV node or AV junction. Okay? So we're going down, right? So if you look at the heart, we're still progressing down the electrical system. Okay? Now we're talking about the AV node. Okay. An impulse generated in the AV node travels down the ventricles and up toward the SA node. So, there's three possibilities. An upside-down P wave, immediately followed by a QRS complex, a smaller P wave hidden within the QRS complex, an inverted P wave after the QRS complex. And then the heartbeat is from 40 to 60. You start seeing a problem now. You see how we're progressing down. The further we get down, the more problems we're going to start having.
If it's after the QRS complex, how do you know it's not the ST segment that's inverted?
I gotta look, I gotta see where I wasn't paying attention. Judge, what was your question? Say it again?
So that the P wave is after the QRS complex, and how do you know it's not a T wave that's inverted or the ST segment that's depressed?
Because you look here.
Because it just is.
Well, if it's junctional rhythm, there might be no beat.
Yeah,
Yeah,
I just think
real.
if it's junctional, it's gotta be, because you got SA, you got
You see
AV
the kids in
node,
the
and then what's comes from the SA node problems.
No. She's asking a legitimate question.
Because you wouldn't look for a P wave afterwards, right?
No, but I would call that's junctional rhythm, because there is no P wave, right? I mean.
Right, but they're also saying the P wave could be inverted also with a junctional rhythm.
It could be inverted with a junctional rhythm.
But I don't see it here. I don't see it. Do you see it in here? I don't
No,
see
I
it
don't
here.
really know what I'm looking at.
It should be before the QRS, the junctional rhythm. It should be right there, inverted, and maybe it is, like, and we're not cardiologists here, but if you look really close, and I don't have great sight here, but there is a little dip there, isn't there?
Right, there's a
before the
dip here.
QRS. Do you
Remember
see
we
it,
said
guys?
if in here, we said that the P wave would be inverted.
But I was asking about the one, if you go slide back, it said after
Yeah, it
the
says that,
QRS.
and I've never seen that. It's right here. You said
Oh,
upside down
three
P,
possibilities.
an
Upside down
inverted
P
P
is-
with wave after the QRS complex.
So how do you know that it's a P wave if it's after
Oh, I see.
QRS? That it's not a T wave, or like how are you
I have never seen.
You talking about in the hospital?
in this?
You know what, Larissa, truthfully, you won't in the field. I'm gonna tell you that right now. This is gonna be hard to diagnose and look at in the field. It's gonna be extremely difficult. You're gonna need a 12-lead EKG to determine this, not just one lead. Okay, so I would think you'd have to go into a 12-lead, take a better look to see where it is. And truthfully, no, this is maybe something I wouldn't even catch in the field. You need a cardiologist.
Okay.
Okay,
I mean,
yeah.
it's hard to see.
So this is This
So
is
we
a
would
junction,
just know
right?
that it's coming from not the SA node and base it
You
off
know
of
it's a
the rhythm.
junctional rhythm, you don't know where it's originating from, you suspect that could be it, because there is no P wave and it's not tacky, so I'm looking at it, so I look over there and look for it. But I wouldn't be sure,
Okay.
okay?
Okay, so we're looking at a junctional rhythm.
Yeah, I just want to be sure, I look for it, I wouldn't be sure.
So let's look at the junctional rhythm. Okay, occurs when the SA doesn't function. The AV node becomes the pacemaker. Okay? So it's not firing at all. The SA node, nothing's firing up there. Okay? So we're now looking at a junctional rhythm. Okay? Most common with significant SA node problems, treatment is usually an implanted pacemaker. Okay? See, they usually put them up here. So that's the pacemaker to fire the atrium. Okay? Accelerated junctional rhythm. Rates exceeding 60 beats per minute, but less than 100 beats per minute. Regular rhythm, little variation between the R and R intervals. Seldom treated out in the field.
Danielle did all this.
Yes.
I'm just confused.
Yeah, she went through all this, right, did she, all the arrhythmias, yeah.
So we're
she
good?
did. Yeah, we're good.
Yeah, we
She
left
went through all
off
the
at
arrhythmias.
asystole, I think, right? With 12 to 12.
Did you get the heart
Left off
valve?
asystole,
We left off at, we stopped
At 12 weeks, right?
and then you should stop, yeah.
Maybe 12 weeks.
We're doing 12 weeks next week. Yeah, it's Monday, so we should stop at 12 weeks. She got you all the way to asystole?
Yep, 12.
And- and
12
you-
weeks.
Okay, then 12 weeks is Monday, yeah, we're done.
Sorry, I just started.
12 weeks on Monday.
Mark right here.
Say what?
Yeah, we're good.
I got fat through that all.
Early night, early night.
No, not this early, no.
Okay. So, some reading material for you. Never say I never gave you anything.